Everyone. Today we are going to talk about preeclampsia markers. So primarily the plan is to discuss, because we all know that preeclampsia is there is a prevalence of about 2 to 5% preeclampsia in our Indian population, and preeclampsia is associated with high rate of maternal morbidity and fetal mortality. So to discuss the various modalities to reduce preeclampsia, to reduce the risk, we have two very eminent speakers with us today, Dr. Chanchal and Dr. Revati. It's our honor, it's our pleasure to have these two eminent speakers here, and we really are looking forward to hear you both. So before we start, we will start with Dr. Chanchal. Dr. Chanchal will be talking about screening modalities in first trimester for to identify the patients who are at high risk of developing preeclampsia. So how we can use the different markers, what are the, how clinically these markers, once we identify, what needs to be done. She will share her clinical experience, that how she has been screening her patient and how she has been using various biomarkers in the clinical practice. From the screening, we will move to diagnosis. In the diagnosis, Dr. Revati will be taking up the newer markers and how they can be used to improve the management of patients. So before we start, I would like to give a brief introduction of Dr. Chanchal. Dr. Chanchal is just a minute, I think it's not. Yeah, Dr. Chanchal is lead consultant fetal medicine at Madhukar Rainbow Children Hospital, New Delhi. She's a member and past chairperson of AOGD Fetal Medicine and Genetics Subcommittee. She is also in editorial board for Journal of Fetal Medicine. She is a regular faculty at RCOG accredited academic program. She is the regular organizer of CTG courses for FOXY accredited ultrasound. She is a FOXY accredited ultrasound trainer at her current center, that is Rainbow Children Hospital in New Delhi, and antenatal screening and management of high risk pregnancy, especially growth restriction, multiple pregnancy, fetal intervention. These are her areas of interest. Welcome, Dr. Chanchal. We look forward to hear.
Thank you very much, Dr. Mary. It's an honor to be able to interact with you, speak to you, and interact with all the audience. So, screening and prevention of preeclampsia is certainly the hottest topic these days because of the amount of information. Nowadays, patients are coming and asking us whether we do placental growth factor in the first trimester or not. So I think as it happened with the non-invasive prenatal screening, where the patients took it up, that we want to get it done. I think this is what is. Hello? Am I audible? Hello?
Yes, you are audible, Dr. Chanchal.
So, as I was saying, that many times tests become the norm because the parents wants to do it. So I think that is going to soon happen with the placental growth factor also. Because in our clinical practice, patients have started coming and asking us, do you do this or not? So now, whenever I want to screen for a condition, there are two prerequisites. A, the disease should be important enough to be screened, and B, I should have a treatment for those who screen positive for the disease that I'm screening for. So, preeclampsia and eclampsia remain a major cause of maternal and perinatal morbidity and mortality. That is, it is undeniable. We are still losing mothers to eclampsia and preeclampsia. The incidence in our country is quoted to be around 10% for preeclampsia. The world over, it's about 5%. And the incidence of eclampsia, the dreaded E word that to which we lose mothers because of this, is about 1.5%. And what is more startling is that this article in the Journal of Obs and Gynae is that eclampsia in India through the decades, there has been no reduction. it has just remained almost at the same level. So you can see this diagram from this paper that I'm quoting, that from 1969 to 2014, the incidence is almost the same. It has never gone down. There is no reduction in the incidence of eclampsia and perinatal mortality over the last few decades. The maternal mortality, of course, has shown a slight receding trend because of increased availability of care to women in large, but there has been no decrease in the incidence of eclampsia. So, and currently,
supposed to be presenting.
I can. So, in fact, the FIGO has taken, because there is so much of evidence in the last few years that we can screen for it with a simple blood test and by doing in the ultrasound in the correct way. FIGO has also taken it up in a large manner. So all these infographics are from FIGO, where they want to highlight that 2 to 5% of pregnant women are affected, and globally 5 lakh newborn deaths are caused by maternal preeclampsia each year.
Other side.
And not the burden of the
Maybe
disease.
you can just try.
I'm hearing a lot of noise from the back end.
Dr. Revati, I request you to mute yourself. Dr. Chanchal, आपका ना screen नहीं दिख रहा है. आपकी PPTs are not visible. Please share your screen.
So, my sharing screen is on, and can you see it when I? Now it is on. Are you able to see?
Yes, ma'am.
Are you able to?
Now we can see.
You can see?
Yes, ma'am.
So the infographic is showing. So what I'm saying is that apart from the maternal and perinatal morbidity and mortality, it is preeclampsia in pregnancy which puts both the mother at a risk of non-communicable disease. And nowadays we are all talking about the fetal origins or the origin of the disease when a woman is pregnant. It has been proven that the left ventricle function in women who've had preeclampsia, it never goes back to its original level once they deliver. So if we could prevent growth restriction, which is the commonest complication that I see with preeclampsia, growth restriction has also been correlated with a lot of non-communicable diseases in life. So it actually gives us an opportunity to prevent non-communicable diseases later in life if I can screen for and prevent preeclampsia from happening. So as I said, the other logical step is for adopting a screening test universally is to have an effective intervention. And I think this answer was given in 2017 by the ASPRI trial, which most of the obstetricians, which most of us are aware of now, in which women who were screened for preeclampsia using placental growth factor in addition to other factors, that was their algorithm which they used to screen low-risk women for developing preeclampsia. These women were treated with low-dose aspirin, that is 150 milligram, and it was given at bedtime after dinner as a single dose, starting from 12 to 13 weeks till 36 weeks. And they probed that we are able to prevent 80% of early preeclampsia that required delivery before 34 weeks. So this paper gives us level 1 evidence that the primary prevention, which is probably the utopia for medicine, I mean, I can prevent a disease from happening, that we can do that using these simple tests that we have at our disposal. So screening should be universal and it must be done. Then how do we do it? So one must be aware of these newer definitions which all the new papers are using. Preterm preeclampsia is defined as the one that happens before 37 weeks. Term preeclampsia is more than 37 weeks. I think that for us is not, I mean, I'm not too bothered about this term preeclampsia because I have the option of delivering the mother. It is the early preeclampsia, that means preeclampsia severe enough to warrant delivery before 34 weeks, that I would want to catch. And it is this category of women that we are aiming to screen for. So as I said, that the ASPRI trial, the results we are all aware of, but what we keep forgetting is that the screening protocol that the Fetal Medicine Foundation used in this paper included mean arterial pressure, the mean uterine artery PI, and placental growth factor. So PLGF was an integral part of this the screening methodology that was used in this trial. Currently, many of the guidelines, including NICE guidelines, RCOG guidelines, they use a point method that you take these risk factors and then you decide if the woman has more than 2 or 3, and then you categorize them and decide whether who needs aspirin or not. Whereas the FMF screening protocol, they have incorporated these parameters also. However, it is a more individual based approach where that individual's mean measurements which are unique to that person is used to categorize women into high risk or low risk. And we don't, so if you go by the checklist method, any woman whose BMI is 35.4 would have one screen positive, one factor positive. Whereas a woman with a BMI of 32 would not have that risk factor. Whereas that's not how it should be. So in the FMF algorithm, what they have done is, for every, for example, if I look at the weight of the mother, every 10 kgs increase would increase the risk factor. And there are protective risk, there are factors which may be protective also. So a woman who has had a pregnancy in which she did not develop preeclampsia, the risk calculation will take into account that as well. So the risk calculation is more individualized and more robust. And in fact, they have validated validated the adoption.
Now I'm able to see. Yeah.
Using this screening algorithm in 16,700 patients, in which they used the traditional screening criteria vis-a-vis the FMF criteria. And if you look at the red bars, that's the performance of the FMF algorithm, which includes the placental growth factor, as compared to the traditional checklist method of these the recommendations which are still being used. And at every single type of preeclampsia, the FMF algorithm performed much better in terms of detection rate. 90% vis-a-vis 47% for preeclampsia requiring delivery before 34 weeks. So when I talk about screening for preeclampsia, what we do in our clinical practice is that we call women at 10 to 12 weeks. The mean arterial pressure, there is a whole paper on how this blood pressure should be measured. So I think it makes sense to modify our fetal medicine clinics into doing things the way they are recommended. So the mean arterial pressure is 2/3 of diastolic BP, added to 1/3 of systolic BP. The mother is asked to rest for 5-10 minutes. She should be sitting. The automated calibrated BP apps should be kept at the level of the heart. An appropriate size cuff is extremely important, especially because we are dealing with women with more and more BMI these days. Each arm is measured simultaneously, and we measure it twice in each arm, so an average of 4. Then on the ultrasound, everybody is getting a scan done at around 11 to 12 weeks, 11 to 13 weeks. So we measure the uterine artery PI. There is again, if somebody wants to read on correct technique of how to do it, and uterine artery PI at 12 weeks is much higher in women who developed preeclampsia later on as compared to women who did not develop preeclampsia later on. Then we come to the placental growth factor. PLGF is synthesized by the placenta and it has potent angiogenic functions. And in pregnancies which are destined to develop preeclampsia later, the serum PLGF is lower than in normal pregnancies, which is a consequence of placental hypoxia. So again, the same algorithm, which you can see on the right-hand side of the screen, the detection rate. If I use just history-based factors, I'll be able to detect only 48% of women who will develop preeclampsia. If I use only mean arterial pressure, it is 55%, a modest improvement. If I add uterine artery PI, it becomes 70%. PAPI does improve the detection rate, but not as much as addition of the PLGF. And if I take into account all factors, the detection rate is it performs the best, 76%, using a cutoff of 1 in 100. So if we go to the Fetal Medicine Foundation website, not everybody may have the privilege of having a software. However, the FMF has made this calculation available free of cost. So I just need to type in the type of pregnancy, whether it's a singleton, whether it's a twin pregnancy. It takes into account the maternal history as well as previous obstetric history, and then the biophysical measurements, that is the mean arterial pressure and the uterine artery PI, and placental growth factor as well as PAPE. So all these parameters can be entered, and the software gives you an assessment whether a woman is high risk or low risk. If you use placental growth factor, you can keep a cutoff of 1 in 100. That lowers your false positive rate. And these detection rates of 90% and above that are being quoted are at a false positive rate of 10%. And those women who turn to be high risk, you give aspirin at the dose of 150 milligram at bedtime from 12 weeks to 36 weeks. So what it means is, out of 100 women who are coming to my clinic, at a 10% false positive rate, I will be labeling 10 women at if 10% false positive rate, 10 women will be labeled as screen positive, who will end up having aspirin. And in 80% of these women, we will be able to prevent the disease from happening. So, and what is more important is the negative predictive value. The negative predictive value is more than 99%. So it's not just women who will need treatment. That number is less. In women who do not screen, out of those 100 women, 90 women, I'm very confident that nothing will happen to them. And I can concentrate on the women who are screen positive. In fact, in coming to Indian data, there is this study from Lady Hardinge Medical College where they used a combination of placental growth factor, PAPE, maternal BMI, mean arterial pressure, and Doppler PI. They also had similar detection rate. So it performs well in the Indian population as well. We always hear about cost. I think even that problem has solved now, because when it started, the triple marker, the first trimester triple, that means the dual plus PLGF, were costing about 4,000. Now most labs have brought down the cost to 3,000. The test must be performed at a certified platform. So you will see a lot of discrepancy in the cost of the dual marker. However, the software, the labs which, when they use the software which is approved by Fetal Medicine Foundation, there will be a marginal difference in the cost. The proponents who feel it is too costly, they feel that why don't we give aspirin to everyone? If the correct dose we know is 150 milligram, and if I give a woman 150 milligram of aspirin without screening, I will probably start it at around 6-7 weeks and then give it till 36 weeks. That also adds up to a cost of nearly 1,300 rupees. So I think the cost is not so much of an issue at present, given the benefits of doing this. There is a FICO consensus which has been published in the International Journal of Obstetrics and Gynecology, where they say that in resource-constrained settings, you can use a contingent screening. That women who are screen positive on dual plus ultrasound parameters, then you do PLGF for those patients. You use that. However, it is practically, it is very difficult to keep asking patients to come in repeatedly for scan or giving blood samples. The traditional combined first trimester screening, in which PAPE and uterine artery PI are used, along with the mean arterial pressure, that also has a detection rate of more than 90%. So the accuracy for predicting preterm preeclampsia was in the range of 90%. And in preterm preeclampsia, it was about 80%. So adding PLGF definitely improves the detection rate and brings down the false positive rate. You treat less women with aspirin when you incorporate placental growth factor in your risk calculation. So currently in the UK, the NHS has not incorporated placental growth factor in their screening algorithm. So this paper from British Journal, what they did was that they looked at the implementation of routine first trimester combined screening for preeclampsia. So what they found out was that if less women are labeled as screen positive, the patient as well as physician compliance for aspirin use was better. And there was a significant reduction in the prevalence of preterm preeclampsia and early preeclampsia. So coming back to the aspirin trial, ASPRI trial, we've already covered most of it. So another common question is, are women able to take the 150 milligram of aspirin? Is it harmful? The adherence in this study was almost 80%. None of the patients had any significant side effect from taking this high dose of aspirin. And there was, as I said, there was an 80%. These are the rates of reduction in preterm preeclampsia. So a 90% reduction of preeclampsia requiring delivery before 32 weeks. And 80% reduction in women requiring delivery before 34 weeks. The effect on women who developed preeclampsia after 37 weeks was not great. There was no significant reduction there. Twin pregnancies, no, the twin pregnancies per se are at a high risk for developing preeclampsia. But the same screening strategy can be adopted for screening and treatment, and a lower cutoff with a higher false positive rate will detect nearly 99% of preterm preeclampsia. So the FMF algorithm, which is available free of cost online, it includes risk calculation for twins also. And it takes the screen positive rate, of course, is quite high because the multiple pregnancy itself is at higher risk of developing preeclampsia. One often gets asked the question, what can we do in our setting? I feel that we can do all of this. When a woman comes in, all women are having an ultrasound at around 12 weeks. One can easily incorporate taking blood pressure in the correct manner in the same setting. One, to calculate the mean arterial pressure, one must do a uterine artery PI and use the multiple of the mean, not absolute values, not looking at the notch. And one can add the placental growth factor to the current policy of doing a dual marker. The problem with us is, I think we have completely two different scenarios, where one setting is the resource constrained setting where we are not even being able to do a dual marker. And the other situation is where everybody wants to do an NIPS. However, the NIPS does not replace the triple or the first trimester screening for preeclampsia because it simply can't predict that. So I think one needs to have, each center needs to have its own policy of what works best for them. But the algorithm must be followed. And if by any chance placental growth factor is not being able to be done, then one would keep a higher cutoff. One would keep a lower cutoff. So your screen positive rate goes higher. So more women end up taking aspirin. I'm often asked the role of pentascreen. There is no validation of the pentascreen as of now, and I don't think it's validated as of now. There's only one paper including 300 women. And because the component, the inhibin is so temperature sensitive, maintaining quality is also difficult. So as of now, there is no evidence to do pentascreen. There have been further meta-analysis of the ASPRI trial, and the one group in which the aspirin or the screening did not perform very well were the chronic hypertensives. So probably we still do not know how best to predict preeclampsia in women who have chronic hypertension. Another meta-analysis was the timing of aspirin. So when started at less than 16 weeks, it works best, and that is why the 12-week window is very important. So this is what I just covered, that if you took out women without chronic hypertension, the aspirin worked even better because it was women with chronic hypertension who did not respond very well to the aspirin. And compliance. So it is very difficult. So when they broke the results of the aspirin trial, women who showed more than 80% compliance, the maximum risk reduction was in that group, and that is not surprising. And that is also one of the reasons why we would not want to prescribe aspirin to everybody, because compliance is an issue. So now, screen positive, the women has been prescribed aspirin. What do we do now? Now, they must be, these women, of course, will be, these are the high risk women, so you would follow them up more closely. They should be reminded of taking the medicine. And I would put them on ultrasound growth surveillance from 26, 28 weeks onwards. And the timing and mode of delivery would be guided by the clinical assessment. So to summarize, I think we've come to a point where universal screening for preeclampsia should be offered. It should ideally be done at 11 to 13 weeks. It must take into account the placental growth factor, apart from history, mean arterial pressure, and mean uterine artery. When you use placental growth factor, you can afford to keep a higher cutoff so that you label less women as screen positive. 150 milligram of aspirin from 12 weeks onwards at night till 36 weeks. Calcium supplementation in women who are deficient in calcium is also proven to decrease the incidence of preeclampsia. The take-home message is aspirin should be targeted to those who need it and not be given randomly. In the last year, there have been 2-3 papers in which performing placental growth factor at an earlier gestation has been looked at. However, there was not much difference. So whether you do a placental growth factor at less than 11 weeks or more than 11 weeks, the risk prediction or the performance of the test in predicting preeclampsia has been the same. So I would like to end with this slide. I would that prevent eclampsia. I think we have reached the point where we can effectively prevent preeclampsia. Thank you very much.
Thank you, Dr. Chanchal. Thank you for the insightful talk. Definitely, we have the message that even I have reached out to you to check that why should we not prescribe aspirin to all the patients. I think your talk on those questions, and also important point, because if we talk about the cost, so definitely if a patient has to spend around 1,300 rupees on aspirin, and definitely there is a side effects associated with aspirin like gastritis and all, so at least we can save the patient from that point of view. Thank you. Thanks a lot. I think we will take the questions at the end of the sessions, and we'll move on to our second speaker, Dr. Revati. I remember that during our undergrads, the definition for the diagnosis of preeclampsia was a woman who develops hypertension after 20 weeks of pregnancy with proteinuria. That was the definition of preeclampsia. That means hypertension with proteinuria post 20 weeks of gestation. But now the limitation has been in various studies, and ACOG also has modified the guidelines for the diagnosis of preeclampsia. Now the presence of proteinuria, because it was identified that some women who do not have proteinuria, still they develop preeclampsia. So now it's not mandatory. Proteinuria is not a like, even if a woman without proteinuria has symptoms such as epigastric pain or like headache or uterine artery PI high. So even in the absence of proteinuria, we can diagnose preeclampsia. So what I have known that most of the clinicians that once still like there is a need of biochemical marker which can help them to diagnose preeclampsia, and once the preeclampsia is diagnosed, if there is a marker which can help them to determine the further management of the preeclampsia. So we have Dr. Revati, who will be sharing her experience that what are the markers which can be used and how to manage these patients. Welcome, Dr. Revati. He is a chief consultant in maternal fetal medicine and managing director in Mirror Health Hospital. She is also a visiting consultant in maternal fetal medicine, Milan, Bangalore, and associate consultant to Dr. Vikas Mehta, again in maternal fetal medicine, Bhagwan Mahavir Jain Hospital in Bangalore. She is a secretary in Society of Maternal Fetal Medicine India chapter. She is executive editor of Asian Journal of Obs and Gynae. She was executive director till May 2018. She is an elected executive committee member for BSOG 1920 and 2021. She is affiliated to BSOG and she is a founder member of Gestosis Indian chapter. She has many awards and publications to her accreditation. To name a few: Yuva Foxy Dr. Kamini A. Rao Orator 2015 South Zone Award, Yuva Foxy South Zone All-Rounder 2016 Certificate of Excellence in the categories of Research and Young Scientist at Second Academic Grant Awards, New Delhi in November 2016. Welcome, Dr. Revati. Over to you.
Thank you so much, Dr. Nimi, and it was a very nice and a enlightening talk by Dr. Chanchal, and it's hi from Bengaluru. Can I just play my... Yes, all right. So we've actually started the preeclampsia story with screening. Now, the question in the mind, because I've had so many women approach to me and say, yes, we were screened positive. We were started on ecosprin 150. We still have a very high uterine artery Doppler. Now, what are we going to do with these kinds of women? Are we just going to stop at screening? It's a very, very wonderful tool to start screening with all women, but then we have to handhold them till delivery. We have to make sure their adverse outcomes are, we limit their adverse outcomes. Now, how do we do this? And this is again with the angiogenic biomarkers. Due to the paucity of time, I'm just restricting my talk to my, I'm going to share the Indian experience, before which I'm going to tell you a little bit about what's happening in the world regarding the SFLT1 PLGF. So my topic for today is angiogenic biomarkers in diagnosis, prediction, and prognostication of preeclampsia, clinical evidence, the global as well as the Indian perspective. Okay, now to understand this talk, you will have to understand that preeclampsia, just like how Dr. Nimi has told very recently, that preeclampsia is no more about proteinuric hypertension. It's about identifying who is the one who has a propensity for adverse outcomes due to endothelial dysfunction, which is the root cause of the problem. So how do we do that? We can do this with the biomarkers. Just to make this conversation very simple, let's identify two important biomarkers. The one is the angiogenic one, and the other is the anti-angiogenic one. The angiogenic one, which is tested till date, is the placental-derived growth factor. So you need more of placental-derived growth factor to be protected against endothelial dysfunction and preeclampsia. In the same way, you need less SFLT1. So you don't want more of SFLT1, which is a consequence of endothelial dysfunction. SFLT1 stands for soluble form of tyrosine kinase receptor, which is again an anti-angiogenic factor. That means it is something that can result or can cause endothelial dysfunction, which is the root cause for preeclampsia. So if you're having a normal pregnancy, like how you're seeing in my slide, the placental-derived growth factor balances the SFLT1. But if you're looking at an unhealthy endothelium, then you're going to have more of SFLT1 and less of PLGF. And this imbalance can result in preeclampsia. Now with this, let's look at the global evidence. All right. So we've already looked at screening. We've already looked at how screening can help. Now let's look at how we can utilize this in the second as well as the third trimesters, how we can use the biomarkers, which is specifically angiogenic, that is the SFLT1 PLGF, which has been tested for almost like 10 years now in clinical studies, for short-term prediction of PE, for preeclampsia diagnosis, as well as prediction of adverse outcomes. Now, if you're looking at preeclampsia diagnosis, because we have a lot of women who are not proteinuric, who may have fluctuating platelets and liver enzymes, and for all you know, they may be normotensive, but may also still be preeclamptic. These are the women that we are missing, and that is why we are making an underdiagnosis. But if we can have a marker which is very objective, you do the test on a very standardized platform and get a number which can be probably even looked at by a registrar, you can definitely differentiate preeclampsia from the benign varieties. So what this SPLIT1 does, whenever you have an SPLIT1 PLGF ratio which is high, it just tells you that you're less protected with PLGF and you have more of SPLIT1, then you know for sure that I'll tell you about the sensitivity specificities as we move on, that this particular ratio increases preferentially in preeclampsia and health-related problems, unlike in chronic hypertension and gestational hypertension, and of course, the normotensive controls. So this gives you a discriminative capability. So if you're not very sure, you have somebody with chronic kidney disease, or you have somebody with normotensive HELP, or you have somebody with autoimmune hepatitis, and you're not able to identify whether there is a superimposed preeclampsia component, you can always do this test. And this test is a simple blood test, and it can probably tell you that that particular woman is preeclamptic or not, looking at the value. I will tell you about the values also in my future slides. Now, let me start from, say, maybe 2012, 2013. We had a typical case control study, which was actually performed by Steven Verloren et al. From Germany, who looked at something like 468 women, and they looked at normal versus preeclamptic women. And they were able to arrive at cutoffs. What did they say? They said that the SPLIT1 PLGF ratio could be best used maybe beyond 20, in their study it was beyond 28 weeks. And they started looking at less than 34 weeks, 28 to 34 weeks, they gave a different cutoff because the SPLIT1 PLGF ratio relatively increases even in normal pregnancies beyond 34 weeks. So they actually looked at a different control beyond 34 weeks by in their comparative study. What they did was they just measured the SPLIT1 PLGF values in their normotensive versus preeclamptic population, and they found that a value of 33 was had a sensitivity of about 95%. That means anybody who was less than 33 was not going to develop preeclampsia. Anybody who was going to be above 85, less than 34 weeks, was going to develop preeclampsia with a sensitivity of about 88%. And this test had a specificity of about 99.5%, which was very, very significant. And they also identified a different cutoff, which was 110 beyond 34 weeks till about 37 weeks. And they said 33 still remained, the cutoff. And you could say anybody less than 33 was going to be benign. And anybody who was going to be above 110 after 34 weeks were going to be the ones who will be predisposed to preeclampsia. In fact, I used this data for my study when I actually, when I did serial surveillance with SPLIT1 in the Indian population. Now, with this background, so we know what is the cutoffs. We know that something which is less than 33 as per the case control study is definitely benign, and something which is more than 85 and 110 beyond 34 weeks is definitely, considered to be sick. Now, how does preeclampsia? So this tells you about how this ratio could be used for diagnosis. So now moving on to how we could use this ratio for short-term predictions. So we have another very interesting study which was published in 2016, and this was the prognosis. It was an extrapolation of the study that we actually looked at, and they used the number 38. What they found in the study, it was a big trial. It had something like 30 study sites and enrolled about 1,273 subjects. And they found that this number 38 of the SPLIT1 PLGF ratio had a negative predictive value of about 99.3% of ruling out preeclampsia within 1 week, and had a negative predictive value of 94.3% for ruling out preeclampsia within 4 weeks. Very important. You don't have to cage all patients in the hospital for surveillance. You did a test and it came negative, you can safely send home because it has a negative predictive value. In fact, the same thing was, I was able to demonstrate the same kind of figures, in fact, something slightly better in my study. And they also found that the positive predictive value of this particular number, which is 38 for ruling in preeclampsia, was about 36.7%. And it's so important to identify who are the ones who are not going to get sick, because you don't really want to use your resources to be monitoring those women who are not going to get sick, isn't it? So this study gave us that kind of an information. Now, if you're looking at prediction of adverse outcomes, again, prognosis did the same thing. It also looked at the combined endpoint measures, which was nothing but preeclampsia, eclampsia, HELP, abruption, fetal demise. And they found that it was not just about preeclampsia, to identify women with preeclampsia, but it also helped in identifying adverse outcomes. Suppose somebody had a value, the same number worked. If somebody had a value of less than 38, this woman was not going to have adverse outcomes. Somebody who had a value between 38 to 85, definitely she was the intermediate risk category. Somebody who had more than 85 definitely had a propensity for adverse outcomes. And the positive predictive value was as high as 98.5%. The negative predictive value to say that this lady was not going to have adverse outcomes was as high as, say, 98.5%. So you would safely stratify those women who would probably be safe and not require monitoring in the hospital. And at the same time, identify those women in the OPD who could get sick and transfer them into a tertiary care so that you could plan delivery, because most of these numbers come in even before the clinical outcomes. Very, very important. I'll show you what happened in my study very shortly. Okay. Now, to summarize, what this prognosis did was tell us that, say, if you had a number at 38, especially in the third trimester, maybe after about 28 weeks, somebody who had a number of more than 38 was definitely going to deliver earlier. They're going to have something like a 17 versus 51 days duration from the day of the test. That means somebody who was low risk had something like at least about 51 days to go forward compared to the one who was going to be positive. The iatrogenic preterm birth was also going to be definitely higher in those women with a high ratio, and definitely the likelihood of an imminent delivery was 2.9 times higher. So we understood that we can make a diagnosis of preeclampsia. We know that we can actually predict the adverse outcomes, and we know that we can stratify. And we know that if somebody is negative in the next 1 week, she's not going to develop preeclampsia. So we're going to rule out short-term, possibility of preeclampsia with severe features. Now, then came the PREOS study, and this was somewhere there around 2015, 2016. And what they did was they actually looked at the clinical way of identifying those women who are going to be hospitalized, and also compared it with the SFIT1-PLGF. And what they found was, when they used both the clinical criteria as well as the SFIT1, at least in 11%, that is in 13 mothers, the revised decision was no hospitalization. That means these women who were considered to be going to get sick because of clinical criteria was said, no, this is not going to be preeclampsia, and they said no hospitalization. Whereas in 6%, that is in about 7 mothers, the revised decision was hospitalization. And in 98 mothers, the investigators made no change in their decision. So, but the final conclusion was, in 17% of women with suspected preeclampsia, the hospitalization decision was changed after the knowledge. That means the add-on value that was added by the SFIT1-PLGF. And if you're looking at this diagram, you'll understand this better. So you had this category here where, the no hospitalization because of clinical criteria turned to hospitalization. And you can see the pink the blue preeclamptics here. So you can say that at least more than 50% in whom the decision was changed to hospitalization developed preeclampsia. That means this ratio was more sensitive to pick up those women who could probably develop preeclampsia. And, you could make decisions about hospitalization and surveillance and probably try to avert adverse outcomes. Now, so just to give you a brief before I tell you my Indian experience, you're going to look at this number 38, which is actually proven by the prognosis, as well as we also had the prognosis Asia study, which said that this 38 is the number which is going to tell you that if somebody is going to be less than 38, especially in the mid-second and the third trimester, she is not probably going to develop preeclampsia with severe features. And I will also tell you what happened with serial surveillance. Somebody who had a low value continued to have low value. So you don't really have to do this ratio many times. Also, there are a lot of trendings that I would want to discuss. And somebody between 38 and 85 were intermediate, especially less than 34 weeks. Somebody between 38 and 110 was intermediate if it was going to be beyond 34 weeks up to 37 weeks. And somebody who was going to be above 85 after 34 weeks, up to 34 weeks, and above 110 after 34 weeks was going to get sick. So we have three numbers: 38, 85, 110, and 38 and less than 38, high negative predictive value, you can send them home, and they're not probably going to develop preeclampsia with severe features for the next 1 week. All right. Now, we have several guidelines, which have endorsed this as a very important tool to add on to the monitoring protocol that we have. When we say preeclampsia, we're behind the liver functions, we're looking at the creates, we're looking at the uric acid, we're looking at the platelets. They're all consequence measurements, and they may not be, that sensitive to pick up preeclampsia. So if you're looking at several recommendations, we have the NICE, we have the European Society of Cardiology, you have the German, Czech, Danish, most of the European guidelines. They have endorsed this. In fact, the European Society for Cardiology has said that the SWIT1-PLGF ratio of less than 38 can be used to rule out the development of preeclampsia in the next 1 week in a woman with clinically suspected preeclampsia. Very, very important. And the next important thing is about the economics, and NICE did this, and they found that, yes, the false positive reduction was about 72%, and definitely the true negatives increased to about 14% if you use the ratio. So this was all about the global evidence. And with all this happening in the rest of the world, let's look at what was, probably what is the Indian evidence. And I'm really glad to share that I was the principal investigator of this study, which was published in December 2020 in Pregnancy Hypertension, and was mentored. It was a collaborative study with the University of Chicago, and was mentored by Dr. Sarosh Rana, who is one of the pioneer researchers in the world in the field of the angiogenic biomarkers. So actually, my experience started off in 2012. I first worked with the PLGF, and I presented this at New Orleans at IZOM. And I actually found that using PLGF, that was my very early experience, I did it only once between 20 to 24 weeks, and I was able to identify those women who would probably develop early onset preeclampsia, put them in the hospital with surveillance, and increase the lead time to delivery, giving them at least a viable pregnancy. And beyond that, I had to move on to the SWIT1-PLGF because I found that this was this added more value because there would be a customized response, because the PLGF is only the protective angiogenesis that you're looking at. But if you're looking at the ratio, you know exactly how much protected each individual is, as far as the endothelial dysfunction is concerned. So my study, the idea started somewhere in 2016. And this was the study, and it was called the ROBUST study. So it stands for Real Life Outpatient Biomarker Use in Management of Hypertensive Pregnancies in Third Trimester in a Low Resource Setting. What I meant was I used this ratio in the OPD, which is not attached to an ICU or a HDU or an NICU. And I found I managed all these women in the OPD. I used the ratio. I had that idea, that time where I could probably stratify them into tertiary care, or maybe, de-escalated them to OPD care by using the ratio. This was a collaborative study with the University of Chicago. And you will understand better when I'm actually describing the study, because this is very relevant to us. It happened in the Indian population, and it was so difficult to get people for serial surveillance, because though we had something like a total cohort of about 50, we had to sample them multiple times. We had something like 135 samples, and that was quite significant because it's so difficult to actually get that kind of numbers when you're looking at SPIT1 PLGF on a serial surveillance protocol. So this was a prospective descriptive cohort study. It was conducted in a tertiary setup in India, that's in Bengaluru. And there was a planned total enrollment of 100. We had the IRB approvals, both from Bengaluru as well as from Chicago. And we did the preliminary analysis twice. I presented this as a poster in the Euro ISSHP Berlin 2017. And then I also presented this at the iShip IZOM World Congress. And I had the privilege of meeting my extended mentors, Dr. Karumanchi, as well as Dr. Ravi Tadani, who also improvised and gave me more ideas about how to improve my study. And finally, the data was analyzed by the MFM team at Bengaluru, as well as Dr. Rana's preeclampsia laboratory at the University of Chicago. And there was comparative data with historical controls, which we initially started, was not included in the final analysis due to the difficulty in data extraction from the archives to suit our study requirements. So it was only a cohort study. It was not a comparative study. So the study design, it was done on singleton pregnancies with chronic, all kinds of hypertension, chronic gestation, because ultimately the patient is not going to come at a particular time. There are a lot of people who are not going to come to you in the first trimester. They're going to come to you at 20, 22, 24 weeks. They don't know what kind of hypertension they have. So you have to be giving, including any kind of person, hypertensive and who's singleton, and you must be able to predict with the ratio. That was the idea. So the recruitment was made between 28 to 37 weeks of gestation, serial surveillance with the SFIT1. So what we did at 28 weeks, because we had the reference study starting at 28 weeks for the cutoffs, that's the reason we used the 28 weeks. And then we serially monitored this. All right. So this was actually I did the study with an IAS. So the study kits was not costed to the patient. That is how we actually looked at, we wanted to see how this ratio behaves in hypertensive women. So we looked at it serially in these patients. So the primary endpoints is it somebody who is going to have the benign form of hypertension? Do we really have to deliver them at 37 weeks? Or can we prolong them to 39 weeks and make sure that they don't have the adverse outcomes, but still have a normal vaginal delivery without any adverse outcomes? So we were just looking at gestational age at delivery in hypertensive pregnancies versus maternal and perinatal adverse outcomes. So we should not be compromising with respect to the adverse outcomes, but take them longer in the safer way with the biomarkers. So we use the same cutoffs like the Stephen Van Loren study. We use the numbers 33 to 85 and more than 85 as high risk. As far as the less than 34 weeks category and more than 34 weeks, we use the number 110. So, and then what we did, we have to identify what is the kind of surveillance protocol that we should have. Somebody who was negative, we did the test again after 2 weeks just to find out how the ratio behaved. And we had some very important conclusions. Somebody who had very low values continued to have low values. So this tells us an important message that we don't really have to look at them very seriously, in the sense we don't really have to repeat the test again and again in somebody who's had a ratio of 2 or 3 or less than 10. And somebody who was borderline positive, we repeated the test after a week. And somebody who turned positive, we stopped repeating because it is not going to be cost effective, and we intensified surveillance. What do you mean by intensifying surveillance? We first counseled them for admission into the hospital, and we said we would probably do bi-weekly tests for fetal well-being as well as maternal surveillance. We did their PET profile. So we did all the consequence measurements. And most of the time when they were in the hospital, it was very easy for us to predict the worsening of an event and took them much before an event, like for instance, an abruption or an IUFT and those kinds of things. So we did have a lot of these women who were screened negative beyond 37 weeks. So we monitored them with a bi-weekly monitoring protocol. And then at 38 to 39 weeks, we gave them a birth plan, and some of them had a normal vaginal delivery because they were all safe and they could have had a better Bishop score when they went up to 39 weeks without adverse outcomes. Now, this was our reference study, which I have already shown you earlier in the global evidence. And what we did, the simple thing, we identified all women with hypertension in the 3rd trimester. We looked at singleton pregnancy, any kind of hypertension, because we were just looking at adverse outcomes and carrying them safely. We did close monitoring in all those women who were intermediate screen positive or, who had a very high risk ratio. So the results, Now, I'm just putting this from the paper exactly because there was a lot of complex calculations. In fact, we had, we had a collaboration with Harvard. So the biostatistician, we were privileged to have the biostatistician from Harvard who did an excellent work as far as putting in these figures. So we found that, most of them who had the high risk, if you're looking at the SPIT1 PLGF ratio, the low risk had something like a 9.4, the intermediate risk had something like a 54, and the highest value that we got on the high risk was 164. And definitely, I mean, that was pretty significant. And then if you looked at, I'm just telling you the relevant points, the age, the different characteristics like the risk factors, the diabetes, or if you looked at chronic hypertension, you looked at PCOS, you looked at single maternal kidney, all that was not at all significant. What was significant is the SPIT1 PLGF numbers in the low risk, the intermediate, as well as the high risk. And if you looked at other significant things that we actually found out in the study was the latency between enrollment and delivery in terms of number of days was definitely less in the high risk group. You can see this, it's something like 26 versus like 59. And this is definitely significant from the with a significant P. And as far as the indication for delivery, most of them were not chronic hypertensives, they were all preeclamptics, and that was also with a significant P. Then if you looked at gestational age at delivery, we found that the ones who had high risk delivered earlier. I'll show you better pictures that we've actually, better graphs we've constructed to show you this in a very, very explicit manner. We also found that, in fact, the population that we were actually looking at had zero IUFDs, so we were not able to identify, how well this ratio could have helped us to avert IUFD because the clinical protocols were already strong enough to avert that. But definitely, if you're looking at a rural setup, this will go a long way to improve, the methods of identifying those fetuses that would die much earlier. And, it's very important to put them into a tertiary level care at that point of time. And we also found that the diagnosis of preeclampsia, when we actually looked at the high-risk population, was much higher. That was a significant P again. And then this is a wonderful picture. This is a graphical representation. To understand this, you'll have to read this as the X as well as the Y axis. Now you're going to have the Y axis, which is the gestational age in weeks. So you have something like starting 28 weeks onwards. And then you have the SPIT1 PLGF ratio, which is marked on the X axis. Now each gray line is a patient. All right. And then you have different dots there. You have the green dot, you have the yellow dot, as well as the red dot. And all these dots are confrontations. That means every time a patient has a test, that means a gray line has a test, it will be marked on the graph as a point. And if it is a green point, it is a low risk. If it is a yellow point, it's an intermediate risk. If it's a red point, it is a high risk. So here you can see a patient who's had multiple green points, say 5 tests and all greens, is going very close to term. If you're looking at somebody who had a yellow point, delivered much earlier. If you had a red point, that was the serious kinds. Somebody who had a green and then you will not find many people having a green and then a red. Very, 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 less number of people, maybe 1 or 2 who had a green and then a yellow and a red. But most of the time, a red was a red, a yellow was a red, a green was always green. So this gave us that confidence that somebody was a 2 or a 3 of SPIT1 at 28 weeks. You don't really have to worry, even if she was going to be a 38-year-old and she's singleton and she's diabetic and she has a good SPIT1 PLGF, that means she's at low risk, then you can probably de-escalate care without causing a compromised adverse outcome. Now you have another picture here. Now you have 3 circles. Now what I'm trying to say is, again, short-term diagnosis. This is what we actually demonstrated in our study, which closely, matched with the prognosis, both the European as well as the Asian. So what we found is, if you're looking at these encounters, anybody who had a value of less than 33, the inner circle, 100% of them did not develop preeclampsia with severe features. So important. If I find out that this lady is not going to be preeclamptic, I can send her home. I don't have to lock her up in the hospital. And if you're looking, this was very close to 98.5% if you're looking at prognosis. So we were trying to reproduce, we were able to reproduce the same thing in our study. And then if you looked at a value of, say, 33 and 85, you will find that the negative predictive value is about 86.36, and the positive predictive value was something like 13.64. That means 13.64% of the patients developed preeclampsia. And if you're looking at a value of more than 85, 60% was the positive predictive value. That means most of them developed preeclampsia. So it is so important, especially in settings like in our country where you have an OPD kind of a management, small clinics, not attached to an ICU, not attached to an ICU. And even before the clinical symptoms of preeclampsia, can happen, if you're able to identify this patient in a more stable way, you can do a very strategic birth plan by which you can save the lives of both the mother as well as the baby. All right. So this was in a nutshell, let me tell you, because this was about 4 years of work. And I've just put in very briefly about what we found in our study. And if I had to consolidate all my conclusions, first of all, it was the first of its kind study to validate real-time use of angiogenic biomarkers for real time, because most of the times it was either in women who had already developed and they had retrospectively looked at it, never used the marker for prognostication. So this is one of its first kinds real-time used biomarker study, and and especially in a low resource setting, low resource in the sense I'm not looking at a tertiary care hospital, I'm looking about a clinic or an OPD, which happens generally in our country, with a relatively high disease burden. Our disease burden is no more 2 to 5%. It's much higher than that. It's not reported, it's not recognized. So it's so important that, we identify all these women who've not had a proper diagnosis of preeclampsia. None of the recruits with a low ratio developed severe preeclampsia within a week of the negative ratio. Very important, even if the cost of the test is going to be somewhere ranging between 3,500 to say 4,500. And definitely doing a test is much better than putting the baby, delivering a baby earlier and putting them into the NICU or putting them into the hospital, which would, or maybe the cost that is actually involved in treating a patient in the ICU, which would be much higher. The study closely aligned with the prognosis, very important. We even looked at the cutoff of 38 because we'd started our study much before the prognosis was published. So we used the cutoff of 33, which is the Verloren study. And then we found that if we took the 38, we were not going, the recruits were not going to be reclassified. So the 38 was still justifiable with respect to our study. That means anybody who was less than 38 was still, negative in our study also. And higher rate of preeclampsia with severe features as well as the composite maternal outcomes were seen in women with the elevated ratio like other previous studies. That means it did wonderfully well in identifying those women with adverse outcomes. In fact, there have been studies, in Europe where they've actually looked at women with high risk factors and, not necessarily preeclampsia. They've actually found that this ratio helps in identifying those women who can develop adverse risk factors. And low risk patients had longer latency to delivery with expected management without adverse outcomes due to severe preeclampsia. What I'm trying to say is women with low risk came to the OPD, maybe once in 2 weeks, went beyond 38 weeks, but didn't have adverse outcomes. So objectively that these women are safe, and it's not, by assumption. So that's very, very important. And serial measurements performed in our study, we based delivery decisions mostly on clinical criteria. So what I'm trying to tell you is the ratio can just guide surveillance. It can step up surveillance, all right? But your decision for delivery is always based on your clinical criteria. So serial measurements performed in our study clearly demonstrated that those with low risk initially continue to remain low risk. Very important. That's what I was trying to say. A green dot mostly remained a green dot. And those with a high risk ratio had more preterm deliveries and a higher frequency of NICU stays, but no IUFD. So the ones with the high risk delivered earlier, we put the babies into the NICU, but fortunately they did not die. So that is so important. And biomarkers in the third trimester, when serially measured, allowed for outpatient management as against prolonged antenatal admissions or observation stays in the hospital, which is definitely a very cost-effective proposition. especially in our country. Our study was prospective and it was consistent with respect to patient care and management. Data collection and analysis was performed in a blinded manner, and angiogenic biomarkers were measured on an automated platform. It was on the Roche platform. And the limitations, yes, it was a small sample size study, maybe the first of its kind. We're planning an RCT very shortly, but we learned a lot of lessons, and it was so difficult to get the patients going and, for serial measurements. So that was something that, and it was real time because we were using it for prognostication. So there were a lot of lessons that we learned through this pilot study. Rate of adverse outcomes was very low in the study population, in our population, which limits evaluation for outcomes like IUFD. This study did not compare outcomes of patients managed clinically without biomarkers. We didn't do that. We were planning to do it with historical controls, but we were not able to get the correct information with respect to comparison. So we dropped that idea and we did it like a cohort study. Long-term outcomes on neonates, we collected outcomes only up to 3 months, but I am doing that. We've had several patients who've delivered with us with the markers, and at least for the last 3 to 4 years, we've not had any adverse outcomes, but we are collecting that. So the future direction, larger prospective studies based on a similar model of serial surveillance with biomarkers in hypertensives would help, hypertensive pregnancies would help prompt and progressive mapping. See, what I'm trying to say is you've done a screening, you've identified a woman who's probably going to develop preeclampsia, you've modified it with ecosprin, but ecosprin is not going to be completely protective. How are you going to map this woman? How are you going to take her to the third trimester? How are you going to use the resources? That all happens with the biomarkers. And how are you going to deprive a woman who's going to come to you at 20 weeks with a previous history of maybe a severe preeclampsia, IUFD? Are you going to tell her there's no way that we're going to identify disease? Or if somebody comes to you late, are you not going to look after them for preeclampsia? So that you can do it with the angiogenic biomarkers. And utility of a single test. We can't think of doing serial surveillance in a medical college setup. So if I'm going to look at SFIT1 PLGF, say at 26 weeks or 28 weeks, I'm going to do one single test and stratify them. At least I'm going to be guarded against those who are going to have early onset preeclampsia or coming through a fit or maybe an IUFD. Use of angiogenic markers as a tool to identify patients that require tertiary care to avoid criticality needs to be explored in a renal center. If I identified somebody with an 85, she cannot be managed in a PHC. She has to go to a district hospital, and that will make a difference. Utility of the test at lesser gestational ages. We've been having reports of these ratios working starting from 24 weeks, which is very important, especially to avoid early onset preeclampsia. So these are my references in a nutshell. And thank you so much for your patient hearing, and I'm welcome to answer your questions.
Thanks, Dr. Devdi. Thanks a lot. I'll now hand it over to Alka. Alka, you please, if we have questions, yes. Please coordinate.
Ma'am, my first question to Dr. Revati, if the ratio is less than 38, does it need to be repeated after 1 week?
See, actually, as we've learned it from a study, if somebody had a value of, say, less than 10, most of the times they remained low risk. But it depends on how you want to use the ratio. See, suppose I used it in my study to look at how the ratio behaves every 2 weeks. But if you had a test, at what gestation have you actually looked at this particular test is important. Suppose you've looked at it at 28 weeks, maybe. If you really want to catch the late onset preeclampsia, you should probably repeat the test at 34 weeks, all right? Or else if there is a clinical deterioration. But if you have a lady, say with autoimmune hepatitis, who's got something like soaring high liver enzymes, and she is normotensive, and you're not very sure whether she's preeclamptic, you can definitely do this test once and say she's not preeclamptic at this particular point of time. So serial surveillance is not a strategy for all patients. But definitely, if you have a low-risk person, say a value of less than 38 at, say, 28 to 34 weeks, I would definitely want to repeat it one more time at 34 weeks, if it is possible, after full counseling, to make sure that I cover the thing of late preeclampsia also.
Thanks, ma'am. Ma'am, can time to delivery be predicted using this ratio?
See, you have actually looked at my graphs. If you had a low-risk person, who had a test, the time from the first test, which was around 28 weeks, to delivery was as high as 51 days. But you had a high-risk ratio, it was less than 3 weeks, all right? So most of these patients ended up in delivery at least in 2 weeks or less than 3 weeks. So I mean, that is what the test told us in our study, and most of the studies from the global perspective, yes.
Okay. Next is how to manage cases of intermediate ratio.
Yeah. See, if you're looking at intermediate, you're looking at somebody between 33 to 85, okay, at less than 34 weeks. And if it's beyond 34 weeks, you're looking at 33 and 110, all right? So in our study, we repeated this test after a week because we were expecting some kind of deterioration, all right? And most of them either had a progressive intermediate test or turned screen positive within 2 to 3 weeks, okay? So what I feel is if you have an intermediate test, ideal to repeat the test at least in a week's time, or if you have looked at her clinically and you've seen her after 3 days and there is deterioration, you can always look at that test one more time just to make sure where she belongs. Please remember that these tests or these numbers are positive when the patient is still stable, so you have the lead time. So it's not when she's abrupting, it's not when she's going to throw a fit, it's not when the baby is going to die. All right. So it's going to be combined. It's going to be maternal and fetal surveillance. So if you have a progressive intermediate value, then you have to sit and do a lot of counseling. Tell them, see, it's worthwhile staying in the hospital because these are the women who can actually have, uncontrolled hypertension or have bad outcomes.
Right, ma'am. Ma'am, another question is, what is the role of glycated fibronectin and its importance in preeclampsia?
See, actually, as far as fibronectin, I really don't have an experience on that, but I've been hearing from some of my contemporary researchers about this. But I'm not sure whether it is completely, because the experience with that particular marker is not as time tested as it is with the SWIT1, because this SWIT1 has been researched for almost like more than 10 years in clinical subjects. So the experience has been vast. We've had the global evidence, we have the Indian evidence, we are all set to do an RCT here. And the sensitivity and specificity of this particular ratio is much higher than what Glyphin could probably give you. And most importantly, the methods by which I can, the ranges, you have a definite number, say for instance, a 38 or an 85 or a 110, which is still a range with respect to fibronectin. But I personally have not used this. So you have multiple biomarkers actually nowadays, because I grew up with the PLGF and now I'm consolidating with the SPRIT1 PLGF because I feel PLGF has a greater negative predictive value. It's almost like the SPRIT1, but the positive predictive value with the PLGF is less. That's because you can have a variant, in terms of the SPRIT1, you can have more SPRIT1 and, a relatively less PLGF, and that's how you have dysfunction. So I feel this is more customized marker, and you have more global as well as clinical evidence over a period of 10 years and other markers, to tell us that we could use this for prognostication, for prediction, for monitoring, surveillance, and those kinds of things. Yes.
Okay, thank you, ma'am. My next question is to Dr. Chanchal. We are getting a lot of queries from the clinician regarding the Penta screen. So, ma'am, what is your viewpoint on Penta screen? Even though there are no lot of evidence are there or any guidelines recommend this test.
Yeah.
So, ma'am, what is your
we are not I would not recommend it as of now because there is not enough evidence to recommend it, and I feel that the false positive rate, in my experience, is much higher with that Penta screen.
Right.
And because see, with these biomarkers, you're looking for two things. One is aneuploidy, Down syndrome. When ultrasounds are performed as per the FMF criteria, the detection rates are more than 90%. So adding biomarkers just to increase the detection rate for Down syndrome when the scan is being performed well, I don't think it serves that purpose. And as far as preeclampsia screening is concerned, the PLGF is the proven marker. So I don't see why we should add additional markers. As of now, there is no evidence to support that.
Okay, thanks. Next question is by Dr. Himanshu to Dr. Revati. Why should we consider SFLT PIGF ratio and not only PIGF in prediction of preeclampsia?
Yeah. See, PLGF stands for placental derived growth factor. In fact, I have worked on the PLGF and I've generated some data which I presented at the IZOM, but I did not publish it in a journal. So, but now with SFIT1, I grew up with the PLGF. That's what I'm trying to say. What happens with PLGF is it's only an angiogenic marker, right? So you can have different values of the angiogenic marker, but it all depends on how much of anti-angiogenesis you have. And that is again a customized situation. Suppose I have more anti-angiogenesis and I have less PLGF compared to the anti-angiogenesis. That is, I'm talking about a higher numerator and a lesser denominator, then definitely I'm going to have endothelial dysfunction. So that's what I'm trying to say. If you're looking at PLGF alone, you can just have a high negative predictive value, but the positive predictive value may not be all that great. And in my study, especially when I did with the PLGF, I found that this, when you actually look at a cutoff, there you look at a cutoff of 12 and 100 as per the Pelican study. So anybody who is less than 12 is going to develop severe form of preeclampsia. That works. Anybody between 12 and 100, we don't know how much they're going to be protected because the SPIT1 can change with gestation. All right. So that is the reason you're not measuring the anti-angiogenic component. So if you're looking at SPIT1 and the PLGF at any particular point of time, you can map endothelial dysfunction exactly. So that is how the ratio works better than the PLGF.
And I think there's a distinction, if I may add, that there is a distinction to be made in screening whether preeclampsia will occur in a low-risk woman, in a woman who's not hypertensive. That is where probably, when we are talking about the ratio, it's about women who already have high blood pressure, but we want to know who will, in whom the severity will be more. So there's a distinctive, there are two distinct patients we're talking about.
And in fact, Dr. Chanchal, what we've actually found is it's not just in the hypertensive women. The ratio actually performs. We have a German study where the ratio has probably looked at endothelial dysfunction in all high-risk women.
Yes.
Right. When you're looking at PLGF from the screening perspective, you're just looking at the levels going down in the first trimester. But what I'm trying to say is when you're looking at in the third trimester, you have to know what exactly is your anti-angiogenesis. And that could be because of oxidative stress, which could be because of so many metabolic factors. So when you're looking at the ratio, you know exactly how much protected this person is. So that's how the ratio performs better.
Okay, thanks. Next question is, can the ratio be applied for multiple gestation or single tone following fetal reduction?
See, as far as singleton and fetal reduction, yes, we can, because I've used it. All right. I've had a lot of women who've, come to me with reductions in the first trimester. Some of them have been spontaneous reduction, and sometimes they have had a fetal reduction, which is done to reduce the pregnancy when it's an ART. But yes, you can use it in them. But as far as multiple pregnancies, there have been some. I did look at some of the literature in Europe where they've actually had different cutoffs, but still it requires a lot of standardization. In fact, when I did my PLGF study, I'm talking about any biomarker as well as a multiple gestation, I did find that when PLGF, because you have two placenta, right? You don't know, you need a different standardization. So you don't know how much protected this person is. As of now, I don't really have cutoffs for multiple pregnancies, but I think research is on the way and we should be having cutoffs. But definitely it has a high negative predictive value. Suppose somebody has a low risk, all right? You know that this lady is not going to develop preeclampsia, but somebody who has a high risk, that is where we are not very sure like how to interpret, but we definitely want to have different cutoffs for multiple pregnancies. We cannot definitely use 38 and 85 and 110 on multiple gestation guidelines.
Okay, thanks. Ma'am, another question is, in your viewpoint, are the clinicians prefer PLGF alone or in combination with beta SCG and PAPA-A?
The question is to Dr. Chanchal.
Yes, ma'am. Dr. Chanchal? I think.
I think I accidentally left the room. Am I?
Okay.
Hi, sorry, I think
Yes, ma'am.
I accidentally exited the room. So, see, as of now, we are talking about two things, as I said. In the first trimester, you want to do screening for picking up Down syndrome, in which the tested dual marker is the beta HCG and the pathway are the biochemical markers, which provide the best improvement in the detection rate. When you add placental growth factor, as of now, PLGF is the one that performs better than PAPI for prediction of preeclampsia. So when we are talking about prediction of preeclampsia, I think it should be placental growth factor. I mean, that is the main proven biomarker that has the most efficacy, the best detection rates. But not standalone. I'm talking about combining it with biophysical and the historical risk factors.
Right now. So, ma'am, there is no further questions. So we can end the session here.
That was an excellent talk, Dr. Reddy. I really
Thank you
enjoyed
so
it.
much,
Very
Dr.
nice.
Chanchal. It's the preeclampsia family, the saga
Yeah,
continues.
I know. So, I mean, I think the most important take-home message, what you highlighted, was that once you label them as screen positive and put them on aspirin, you just don't stop there. Those are the
Absolutely.
women to concentrate on.
Absolutely.
Yeah. And the biggest
In
role
fact,
of
I
that is
have those women who come to me. I'm raising my own support groups. They tell me, it's like I've been told, I'm positive, I'm taking ecosprin, but my pregnancy is not doing so well. So do you think I should have an IUFD like what I had before? So you need to have a tool, isn't it?
right. And in fact, the split PLGF ratio is very reassuring. So, as you said, the green dots will remain green. So, if you have a woman who had a stillbirth in the previous pregnancy, even though she may be screen positive, because once you put in the risk factors, most of them will be screen positive. But once you can tell them that we have an objective parameter to say that nothing will happen this time, I think it's very reassuring.
They usually believe in the numbers rather than telling them about clinical criteria, when you tell
And
them.
in clinical practice, if I have 100 women in my clinic, I want to know exactly those 10 on whom I have to focus. So I think that's very important.
So, Dr. Reddy and Dr. Chanchal, like what I have been hearing, like it's not the first webinar. I think earlier also many, like pre-COVID era, we have conducted many CMEs also on preeclampsia, and I always find that clinician, they take keen interest in preeclampsia marker and all these. Still, I find that when it comes to prescribing, so it's they are very, very prohibitive. So what do you think? It's like it's lack of awareness, or it's like, what is the factor which prohibits them from prescribing the test? What is your experience in that?
You want to take that first, Rachel?
Definitely. Yes, that's correct, actually. But I feel now the times are changing, or maybe because I've been talking so much about the ratio. And, in fact, I've had some of these clinicians who call me and say, I want to do this test, or I have this value. Now, how do I interpret? And I tell them, because what prohibits them is they rank this test along with the other markers like the liver function or the uric acid or the creates, and what I tell them is, see, your other markers are normal and she's screen positive. That means she's going to have a problem. So you're going to get that lead time. So basically you should help with analysis, how to interpret a report. And a lot of counseling, like how Dr. Chanchal said, it's a very objective way of doing it. So you have a patient in the OPD. I have many patients who are not very literate, but I tell them, see, this is what happened. This is the number. That's why I'm admitting you. They'll believe you. But if you say, I feel that you're going to throw a fit, she's not going to listen to you when she's stable. So what I feel is awareness, and awareness is building on. I would rather request some laboratory to support the clinicians to do this test so more often and get us the reports, because when I was doing my study, I was able to get the reports because it was, based on an IAS, and I finished my, study on a Roche platform. Once the study was over, the accessibility to the tests, there are very few labs who do it. And they don't know the importance of the test. They draw the sample and they give the report after 2 days when the patient is already delivered. So basically the clinicians need a very strong lab who can understand the science behind this test and make a difference to the population. That's what, I feel is lacking right now.
So,
as far as
Yeah, yes, Dr. Chanchal.
So as in the setup, I mean, Rainbow has started only in 2017 and in Delhi. So we've been trying to get everybody to do PLGF. I find there is a lot of resistance because of that cost factor. Because as clinicians, they would, oh, already this is costing so much, and the scan is costing so much, and you add another another placental growth factor, another 1,500 rupees up. So I think one of the main factors which inhibits clinicians from doing this is the added cost. Second, I think the false positive rate is very high, because what happens is that a low PLGF will make you downstream positive, and then there is this conundrum of screen positive from for trisomy 21, and everybody is concentrating on that. So I think what actually needs to be done is correct protocols need to be followed. So the reporting must include all parameters. My false positive rate must be looked at. That I should not be labeling 50 women in my clinic who come as downstream positive just because I use only antivirus calculation. So I think there's a lag on both sides. However, a very welcome change that I've noticed in the recent past months is that patients themselves are coming. That will you? I've heard of this test. It looks for high BP. Can you please do it for me? So I think now the patients have started questioning their clinicians, and that's how it's
Absolutely.
coming.
Okay, that's good to know that the patients are also the awareness about
So I think
PLGF.
the lab should focus on the patients rather than the clinicians.
Patient education. So our marketing team is there. So that's a take-home message for them also, that
Make
now we
women
should
aware of what all is possible.
Yes, definitely. Okay. Thank you, Dr. Chanchal. Thank you, Dr. Revati. I think looking at the time, we should end the session, and we will be, I'll stay in touch with both of you. And it's really good to hear both of you. Thank you. Thanks a lot for taking
Thank you
time.
for
Thanks so
having
much,
us.
Dr. Nimi and everyone. Thank you.
Thank you, Dr. Chanchal. Thank you, Dr. T. And
Thanks
Thanks,
for
thank you.
organizing.
Thanks a lot.